Good
Jerry,
morning, Roger.
Nelly.
Morning.
Hey, good morning. All right. How you doing?
I'm good. And yourself? How you been?
I've been all right. How
Yeah,
you been?
I'm good. I'm good. I'm
Yeah,
blessed.
how you doing? All right. Yeah, deep voice. How you doing? All right.
All right. Good morning, everyone. I'd like to thank everyone for joining us today for the City of Patterson Ryan White HIV/AIDS Program Clinical Quality Management Committee meeting on June the 14th, 2022. So a brief overview of today's agenda. We'll do welcome and introductions, a report from the recipient's office, and there's several items there. Q&A, question and answer for subrecipient technical assistance needs, CQM committee training, updates from the CQM plan, updates from RDE and eCompass, and subrecipient operation updates as well. So very quickly, we will go through and do a roll call. Oops, that's not what I wanted to do. And make sure we have a representative here from each of the organizations. Please keep in mind that clinical quality management attendance and participation is mandatory and is part of each subrecipient's contractual obligations. With that being said, we will start out. I know Miss Paula just came in, so perfect timing, Miss Paula. Bergen Family Center, if you would introduce yourself and tell us your position at your organization. We'll start out with Paula.
Hi, sorry, I was having trouble finding the link. I'm Paula Tenebruso. I supervise the HIV and AIDS services at Bergen Family Center. I'm a licensed clinical social worker, and we do early intervention, outreach, and mental health.
Great, thank you for joining us, Paula. Anybody else from your organization with you today?
Graz is on another, she's not here today.
No worries, okay, just checking. Thank you, Paula. All right, Buddies of New Jersey. We have a representative from Buddies of New Jersey. Capco. Miss Tisa, you can kick it to Jerry.
Good morning, everybody. Tisa Smith from CAPCO. Medical Case Management, Hopper Supervisor.
And Jerry Dillard, Executive Director and CEO at CAPCO Research Center.
Great. Thank you both for joining us today. Anybody else from CAPCO? All right, Passaic Alliance. Do we have any representation from Passaic Alliance today? All right, and Hackensack University Medical Center. Miss Donna or Miss Irene, are you with us today?
Ms. Donna just entered the room.
Oh, okay.
She might be connecting the.
No worries. All right, perfect. We'll come back. Hyacinth Jokabed, are you with us today? See Jokabed and
yes, I am.
Perfect.
Hi, everybody. I'm Jokabed, Client Service Manager at Hyacinth Patterson.
Great. Thank you.
Join the meeting.
Thank you for joining us today. Northeast New Jersey Legal. I think I see Mallory. Is that correct? Oh, you may be on.
Oh.
There you are. Oh, I can hear you now.
Sorry. Good morning, everyone. Mallory West. I am the Development Associate here at NNJLS, and I'm standing in today for Leah Ash.
Awesome. Thank you, Mallory. And Patterson Counseling. We have Alicia, are you with us? Miss Karen, anybody from Patterson Counseling? Patterson Department of Health? All right, Payne, Roger Lester.
Yay.
Roger, you're on mute, sir.
CEO, Executive Director of Pain. Do non-medical case management, substance abuse, outreach, and health education.
All right, perfect. Thank you for joining us, Roger.
Jerry Dillard, Chief Operating Officer at Pain.
Hi, Jerry.
Thank you again, Jerry. Perfect. All right. St. Joseph's Hospital. Anna, are you with us today? Or anyone from St. Joseph? St. Mary's General Hospital. Priscilla, I see you. Thank you for joining us. You may be on mute, Priscilla.
I'm so sorry. I'm just trying to unmute myself.
You're
Hi, this is Priscilla Michelle.
Perfect. Thank you for joining us. Anybody else that's with you today, Priscilla?
No, we're in the middle of training for Epic Ambulatory, and I have a couple of vacations, so
No worries.
I'm going to stay on as long as I can.
Perfect. Thank you for joining us. I know y'all are, that's a huge leap to go to a new EMR. So thank you, thank you, thank you.
Yes, thank you.
Yeah. All right. Straight and narrow, Miss Gloria, Miss Constance.
Good morning, Gloria Price, clinical case manager.
Thank you.
Good morning. Good morning. I'm Connie. I'm a substance abuse counselor intern here at Straight and Narrow.
Good morning. Thank you, Miss Connie. Miss Gloria. Team Management 2000, Jackie. Anybody from Team Management 2000? All right, let's go back. I saw Alicia.
Yes,
Oh,
Michelle Harvey from Team Management 2000, substance abuse counselor intern.
all right, perfect. Thank you, Michelle. All right, and then I saw Alicia from Patterson Counseling. I believe I saw you join. Are you still with us? All right, going back through really quickly. Buddies of New Jersey. Anybody from Buddies of New Jersey?
Carolina from Buddies.
Oh, perfect, Caroline. Thank you.
Thomas, we do have someone from Patterson Counseling. She's in the chat.
Oh,
I
do not want to butcher your name. So thank you for joining us. Perfect. All right. Miss Donna, are you with us now from Hackensack, or Miss Irene? You may be on mute.
Hi, can you hear me?
Yes, ma'am.
Oh, thank God. Okay. Hello, it's Donna and Irene. We're from ID Outreach of Hackensack University Medical Center. And I'm the patient care coordinator, and Irene is the medical secretary, and we run the clinic.
Awesome.
And I'm sorry I can't get off of this non-video thing, but
no worries. We appreciate you joining us. And then finally, Passaic Alliance. Anybody from Passaic Alliance? All right. Thank you all again from joining us. So we'll go directly into recipient updates, and Millie, I'll hop in and help you with some of these, with going through some of the initial findings from the virtual site visit. So our first up, I guess I can continue to share. Let's do that.
I don't think you should touch it.
All right, let's see here. Notice of award. Any updates on notice of award, Millie?
Not as of today. I did send various emails to Priscilla, who is the program officer. She stated that we should have had it by Friday, but it's already Tuesday. I sent her another follow-up. If I don't hear from her anything, I will send one to Chrissy, May, and her, because as it is, I know they're all out, so I'm not understanding what's the delay. We were able to get everything completed with SAM.gov, so that's not the issue there. The expenditure report was finally sent yesterday, but they knew we were working on that. I'm not understanding what seems to be the holdup, so I'll give them till probably the end of business day today before I send another email out to the parties I mentioned before.
Okay, great. Thank you, Millie. All right. So as many of you may know, we just recently completed, and we don't need captions. There we go. All right. We recently completed our HRSA Hab virtual site visit a couple of weeks ago. Overall, I think it went very well. Things that we already knew we needed to do, system-wide outside of CQM. Also, things in the planning council wise that we knew we needed to fix, like some more recruitment of some participation from people who receive services, and making sure we look more like our epidemic with our Latinx community. And then for CQM, I am very excited to announce we had only one finding, and that one finding is very minute. And the one finding we have to do is, as you know, we have a yearly CQM plan. And we know there has been some changes to our CQM plan with leadership structure and some couple of other items. And we had been waiting till the new update to make those updates in our CQM plan. Though the finding we received is we should update that plan as a living document throughout the entire year. So we are not bound by year to year CQM plan updates, that we should just make them as they happen. That's the only finding. They liked our CQM plan. They like the projects we're working on, and they like the direction that we're going. So shout out to all of you who have made a continuous commitment to clinical quality management and quality improvement in our jurisdiction. From here, it's only going to get better. So now that we know we're on the right track and we got some really great feedback, we are going to go full steam ahead with our clinical quality management program. So next, Millie, talk about some changes in leadership in our CQM plan that was going to take place for this year.
So basically is for the time being is going to be collaborative research, all the sub-recipients and myself. Dr. Mendes is no longer with us. That was one of the things that was requested. I want to say back in 2019, we followed up on the things that they wanted us to do, but at the end of the day, that wasn't happening. So that's when we decided to take a different turn. So I just want everyone to know that he will not be with us going forward. For the time being, collaborative, and I will take full charge of the CQM with sub-recipients doing their part, because at the end of the day, it's not just about collaborative and the recipient putting things together if the sub-recipients do not deliver. So that's where we have to actually have all those components in place. Anything else that I missed on
Nope,
that?
that's it. Perfect. Thank you, Millie. So one of the things that we will be working on this year that we have not done in the past through the CQM committee is when you go through your annual monitoring process for quality assurance or chart monitoring, fiscal, universal, and programmatic monitoring, we will also be conducting an organizational assessment for each organization, and that's specifically for clinical quality management. And so we'll be using the CQII tools and completing those that organizational assessment. And what that will do is kind of outline the needs of each subrecipient and their availability to complete or participate in quality improvement activities. So this will be just an opportunity for us to identify, when I say us, the leadership of CQM, to identify technical assistance opportunities outside of those you're already telling us about, right? I think we've started out CQM in the last year from a very ground level of talking about plan, do, study, acts, and how to get that. We've initiated one. We've already completed one entire cycle. So in August, we will kick off our next clinical quality improvement projects. And then later today in this meeting, we will also hear from RDE and eCompass on some new innovative reports that you are going to be able to run for yourself and to really keep track of your care continuum within your organization, which in essence will help you with quality improvement projects and identifying some of those clients who are not retained, linked, or virally suppressed. So you'll be able to, kind of direct those projects around that. And then finally, the next announcement is that we will be going back to in-person CQM meetings on July the 12th. We are going to make it a hybrid method. However, it is highly preferred that you come in person. Millie and I are still working out the logistics of a provider meeting that will either take place the same day or on the 13th, just to kind of dependent upon what people's availabilities are. And the provider meeting is for, the Part A program and contractual obligations for the Ryan White program. And so, so please mark your calendars for July the 12th from 11 till 12:30. That one's already on the books. And then Millie and I will circle back with you about sub-recipient provider meetings either the same day or the next.
Excuse me, did you say July 12th?
I think so. Yes, sir. Did I get the date wrong?
July 12th is a planning council meeting.
Right.
July 12th is planning council.
Brown, brown. All right.
Mhm.
So Jerry, you're excused from planning council that day, sir. No, I'm playing. All right, all right. All right, we may have to go back to the drawing board on that.
Thank you, Jerry. You beat me to the punch.
How does the 13th look for everybody from 11 to 12:30?
It looks fine to me.
All right. So soon in your email, you will be receiving, let's see here, July 12th, an updated
For us,
Thomas,
we
I
can't do
have
it on the 13th. Donna won't be here.
Yeah, I'm
Okay.
away with my daughter for her birthday.
Okay.
and I have a conflict. I'm going to be at the hospital.
Okay. Okay.
Thomas, did you say that was going to be hybrid?
It will be hybrid. Yes.
Okay. Yeah, we're going live the week of the 11th and the week of, I should say, July 11th. And we have people here the week of the 11th and the week of the 18th, just making sure that we're trained okay. I could probably try to work around the schedule to get on the call if it's hybrid.
Okay. Okay. Yeah, we can play that one by ear, but yep.
Yeah. Yeah.
Okay. Perfect.
Thank you.
Thank you, Priscilla. All right. I just sent out that calendar invite for a save the date and hold that place.
I could have Graz stand in for me, I guess.
Yes, that'd be perfect. Yes, ma'am. Please.
What's the time on that again?
11 to 12:30.
Thank you.
You're welcome. And hopefully by now, you were able to receive that updated calendar invite as well. And I'll go back to sharing. All right, share screen. Oh, nope, wrong one. This will be a very quick, brief share screen. All right, next, training and technical assistance. I know we use Basecamp to ask that on a regular basis, and we know that we have been passing those along to our AETC, and that's how the trainings have been recommended and coming out of the AETC as well from Rutgers. And besides like training for eCompass, which we will address in the provider meeting, are there any other technical assistance needs for quality improvement or clinical quality management at this time?
Yes. Apparently, I'm gonna just put my stab in before I have to jump off. We are putting in data for CD4 and viral load for our clients, and it's not being reflected in the CSS report. We checked a couple of them, a number of them actually, and when we put in the updated CD4 and viral load, it is not reflected in the CSS extract report. We just ran it this morning. It's not doing it. That's the technical assistance we need. How do we have the data reflected in the CSS extract report when we're putting it in? What do we need to do differently?
All right. And do we have RDE with us? I think I saw Robert. Robert or RDE. I think Pakiana's with us. All right. Well, Jerry, we'll circle back on that when they get ready to do theirs.
Oh, no, I'm back on.
Yes, sir.
Yeah, I was muted. All right.
Okay, no worries.
Yeah, so it'll depend on the parameters you're running for the report. So I think that one runs on the date of service for that client. So if they didn't receive a service within that period of time that you had selected when you ran that, it may be why they're not showing up.
No, no, that's not it. Because we did the report from September of 2021 to March of 2022, which is, the second part of the year. that person or multiple people we're seeing multiple times during that time period. We're running it for all contracts for that time period, all services. And it's not showing up on the report.
All right. Well, if you want to email support, and if you have an E2 ID of one that should be showing up, just put in there. We'll take a look at why that client's not showing up in the other ones as well.
You got that, Tisa?
Yeah, I got that, but that's the same answer I got in February of 2022, and it still has not been fixed. Because our last meeting, we talked about the same thing.
Yeah, just send it over. And we'll take a look at that, see if we can figure out what's going on with that.
I do have a question for the other subrecipients. Is anyone else having the same problem? We haven't checked.
Is anyone looking at a CSS extract report besides us?
No.
No, probably not.
Right.
Because that's a very different report.
Right.
I tried it and had a problem with it, so I don't know if that's resolved. And, you know, I still have to get things settled with sharing clients as well, because that affects our data.
That's correct, Paula.
Hopefully today, when we get the presentation from RDE about a new component, a report component that might work a lot better, I suspect, than the CSS extract, maybe Jerry and Tisa and Paula, that it's a lot easier to run, and it might immediately address who those clients are in particular parameters of the care continuum. So let's look at that today. And Tisa, if you could maybe run yours like real time while we're sitting here to see if it kind of updates some of those. And we'll show you when Robert and RDE get to that portion, see if that like fixes some of those problems that you suspect that are already taking place, and see if that new report addresses those.
Because this report that I'm looking at right now was ran at 10 o'clock this morning.
That's the CSS?
Yeah.
Okay, yep, we're going to show you a new report that's in a different section today.
Okay. Okay.
I suspect that's going to answer some of those questions and kind of
hopefully
make the CSS extract a little more obsolete. Hopefully, fingers crossed. All right. All right. Next, we are going, any other questions? My apologies. Any other questions about training needs or technical assistance needs? And that's not to negate Jerry's question about the CSS extract. So I have that on the list, Jerry. So when we get to the RDE training today, we can see if that kind of answers that or updates that for us. And if not, then we will continue to work on that extract report as well. All right.
Join the meeting.
Thomas,
Yes, ma'am.
is this appropriate time to is this appropriate time to talk about the treatment adherence question that I had was talking about before, or do you think I should hold off on the treatment adherent portion for another committee?
Oh, sure. This is a great time for you to ask.
Okay, when it comes down to clients that are in need of treatment adherence, that what process that all the recipients need to do to make sure that all the clients, not just one, not just two, all the clients need to make sure that they are being treatment adherence, meaning that they make sure that they keep their doctor's appointments, make sure they take their medications, make sure that they are well taken care of themselves when it comes down to wellness.
And Angelica, that's a great question. And I think today's training from RDE on the care continuum will really look at some of those key components that you're talking about with linkage to care, retention in care, and ultimately the viral suppression. So I think two key data components that you're speaking of would directly reflect itself on retention in care, meaning they've had 2 care markers in a year, and
Uh-huh.
ultimately viral suppression, which means they would, not always, but 99.9% of the time would be adherent to their medications and medical visits and appointments.
Okay.
And so part of the clinical quality improvement project for subrecipients would be to look at how they can increase those percentages or numbers along that care continuum. And that in effect would address retention and linkage in the viral suppression rates for each of the subrecipients, ensuring that clients are getting treatment adherence and appointments as they need. That's a great question, Angelica.
Okay, thank you.
You're welcome. Did that answer your question a little bit?
Yeah.
Okay, perfect, great. All right, next we will receive our training today on policy clarification notice 1502. I just wanted to reintroduce this policy clarification notice because per se, this is kind of our marching orders from HRSA-HAB on what our clinical quality management program should look like, what components are required for the clinical quality management program, and what does that mean for us as a committee. And so my colleague, Michael, are you ready, sir? You may be on mute. Mike, are you with us, sir?
Sorry, sir, I had to bio break.
No worries, no worries. All right, I will start sharing. All right, it's on you, sir.
All righty, how is everyone today?
Thanks.
Today I will be giving an update on the policy clarification notice 1502, which talks about clinical quality management. What is the purpose of PCN? The purpose of PCN is to clarify the HRSA Ryan White HIV and AIDS program expectations for clinical quality management programs. Here's a little bit on the background of this. So Ryan White HIV and AIDS programs are required to establish a CQM program to assess the extent to which HIV health services provided to patients under the grant are consistent with the most recent public health service guidelines, otherwise known as the HHS guidelines, for the treatment of HIV disease and related opportunistic infections, and also to develop strategies for ensuring that such services are consistent with the guidelines for improvement in the access to and quality of HIV services. What are the components of a CQM program, you might ask? A CQM program is the coordination of activities aimed at improving patient care, health outcomes, and patient satisfaction. To be effective, a CQM program requires infrastructure, so that's the staff resources and conceptual outline of the CQM program, performance measurement, the data that will drive the improvement activities, and quality improvement, activities undertaken in response to the performance data findings. CQM activities should be continuous and fit within the support of the framework of grant functions. Recipients are strongly encouraged to use the National HIV/AIDS Strategy from 2020 to frame CQM activities and goals. All right, I have a quick little true, false, yes, no question for you. A CQM program is doing really well with health outcomes like viral suppression. The TGA is at a 90% viral suppression rate. Is the CQM program still needed? What do we say, folks?
So show us a thumbs up, a thumbs down, agree, thumbs up.
I say yes.
Disagree. Sorry,
I say,
Tisa.
oops.
I say yes.
Yes.
I said true.
True. We're at 90%.
You're looking for 100.
Great answer. Trick question.
The answer is yes. A CQM program is still required. According to the Title 26 of the PHS Act, Ryan White HIV and AIDS programs Parts A through D are required to establish a CQM program that includes activities at the recipient agency and at all funded subrecipient organizations. So yes, it is necessary. Infrastructure. Appropriate and sufficient infrastructure is needed to make the CQM program successful and sustainable. Infrastructure is needed to plan, implement, and evaluate CQM program activities. Ryan White HIV and AIDS program grant funds can be used to establish an appropriate infrastructure for a CQM program. An ideal infrastructure consists of leadership to guide, endorse, support, and champion the CQM program, a CQM committee that develops the CQM program and corresponding activities, all of us here today, dedicated resources and funding that's adequate for CQM infrastructure and activities. CQM costs include training and capacity building, membership dues for CQM related professional organizations, quality related certification, recertification, and continuing education, and the cost to implement CQM activities like collecting performance measurement data. A clinical quality management plan that describes all aspects of the CQM program, including infrastructure, priorities, performance measures, quality improvement activities, action plan with a timeline and responsible parties, and evaluation of the CQM program. It also includes involvement of people with HIV that reflect the population being served to help ensure that the needs of people with HIV are being addressed by CQM activities. It also requires stakeholder involvement, subrecipients or other recipients in the region, planning body members, and its committee members. That provides input on CQM activities to be undertaken. And finally, it requires a plan that evaluates the effectiveness of the CQM program to ensure that the CQM activities are making changes that positively affect the outcomes. Performance measurement. Performance measurement is the process of collecting, analyzing, and reporting data regarding patient care and health outcomes on an individual or population level and patient satisfaction. In order to appropriately assess these outcomes, measurement must occur. Measures should be selected that best assess the services the recipient is funding and that reflect local HIV epidemiology and identified needs of people with HIV. Recipients are strongly encouraged to include HRSA HIV and AIDS Bureau measures and National HIV and AIDS strategy indicators that align with the national goals to end the HIV epidemic.
So more particularly, when we look at how to determine performance measures, our service utilization data is one of our key components of determining how many performance measures HRSA HAB requires us to have according to Policy Clarification 1502. So here in this chart is the outline or guidance from HRSA for us to determine how many performance measures do we need. So if a performance or a service category is only serving less than 15% of our total client population, that's our denominator, then we are not required to track a performance measure for that particular service category, right? If that greater than 15% and less than 50% of clients in the TGA are receiving that service, then we are required to have one performance measure. And if the service category is servicing more than 50% of our clients, we are required to have two performance measures. And this is a chart, I believe, from 2019 for our TGA. If you'll see, our denominator of services was 1,691 clients. And then here in the performance score is the percentage of clients utilizing that service. So you'll see in medical case management, 25% of those 1,600 were receiving a medical case management service, meaning that one of the clients, we have to have one performance measure for that particular service category. And then if you look at, for instance, outpatient ambulatory, 23% of our clients were receiving that in accordance with one performance measure. And outreach services, again, 35% of clients receiving a service there. And again, one performance measure required. So that's kind of how we have to update this on a yearly basis based on the prior year's service utilization data. And so we'll be looking at this again and updating our CQM plan to include the 21-22 grant year and that service utilization data so we can reflect upon the number of performance measures we are required to track according to HRSA.
Alrighty, so Thomas has done this yet again. He stole my thunder on what this slide is with that last little presentation. Performance measurement. Recipients should identify at least 2 performance measures for the Ryan White HIV and AIDS program service categories funded by direct Ryan White HIV AIDS program funds, rebates, and/or program income, where greater than or equal to 50% of the recipient's eligible clients receive at least 1 unit of service. Recipients should identify at least 1 performance measure for Ryan White HIV and AIDS program service categories where greater than 15% and fewer than 50% of the recipient's eligible clients receive at least 1 unit of service. Recipients do not need to identify a performance measure for Ryan White HIV and AIDS program service categories where fewer than or equal to 15% of the recipient's eligible clients receive at least 1 unit of service. Okay, so does everyone get that? Have we hammered that home? So greater than 50%, we need at least 1 unit of service. We need 2 performance measures for that. Between 15 and 50%, we need 1 unit of 1 performance measure. And then under 15%, we do not. Okay, recipients should analyze performance measures data to assess the quality of care and health disparities and use the performance measure data to inform quality improvement activities. Recipients should have an established process to collect and analyze, e.g. calculate the numerator, denominator, and percentage performance measure data at least quarterly. Next slide, please, Thomas. Thank you. All right, back to a true false. QI projects are required for each funded Ryan White HIV and AIDS program service.
True.
I heard a true in there. Okay. False. But all funded services should be assessed through performance measurement to evaluate the effectiveness of the service. If the performance measurement is not meeting expectations, then a QI project to address the service should be implemented.
So those of you who said true, keep in mind that earlier when we talked about if the performance measure was, clients receiving less than 15% of the total population, then we did not need a performance measure. So that's what made this question false. Not every service category needs one unless more than 15% are receiving that service, right? Once we all become quality improvement and CQM experts, you will probably have a performance measure for every service category because this will be, like reading to everybody. It would be very easy and we can achieve those performances.
Gotcha.
All right, next question for you. Recipients should analyze performance measure data to assess the quality of care and health disparities and use the performance measure data to inform quality improvement activities.
True.
True.
All right, Thomas. True. Recipients should have an established process to collect and analyze, calculate the numerator, denominator, and percentage performance measure data at least quarterly.
Right. So you're
Good
probably
job,
thinking
guys. We
like,
got
how
that
is,
one.
oops. Yeah. So you're probably thinking like, what is the difference between this question and QI projects are required for each funded Ryan White service? And are we analyzing performance measures, right? So when we go back and look at this chart, this is where we're analyzing the performance measures and determining, what needs to be done. And then when we get to this section, we analyze the performance measures on an annual basis through our quality and assurance measures when we come out to do chart monitoring. And so when we start seeing that some of those performance measures aren't being met, even though they might not require a quality improvement project, that is definitely something that Millie's office tracks on a regular basis to determine the quality of care that's being given to our clients. Does that make sense? Or did I confuse you more? Okay, I don't want to confuse you more. That's the difference between CQM and just regular quality assurance.
All righty, moving on, we have quality improvement. Quality improvement entails the development and implementation of activities to make changes to the program in response to the performance data results. To do this, recipients are required to implement quality improvement activities aimed at improving patient care, health outcomes, and patient satisfaction. Recipients are expected to implement quality improvement activities using a defined approach or methodology, a model for improvement, or a lien program. Does anyone have any questions for you? For me? Misspoke there, sorry.
No, everything is very informative. Thank you.
Thank you. Thank you for letting me join you and give this little presentation. Thomas, I'll pass it back to you.
Oh, I've been talking the whole time on mute. Thank you, sir. Yes, sir. Jeez. This presentation, keep in mind that when you go to Basecamp, let me see if I can show you really fast if it's going to let me. When you go to Basecamp, keep in mind that I don't have Basecamp open. Basecamp. All right. All right. How did it change from my Google? Give me 1 second. Gotta love this thing. There we go. All right. So when you go to Basecamp, to find things that we presented in the past or just to review those, you'll have in your Basecamp Clinical Quality Management Committee for Bergen-Passaic, right? Open that up, click on Docs and Files. And for each meeting is all of our data presentation. So if you want to go back and review it, if you want to watch the video from the meetings, they're in here as well. So you have tons of opportunities if you've missed a meeting or you just want to go back and refresh yourself with what was presented. Again, that was the January meeting, the February meeting, and then the June meeting here. So the video of today's meeting will go in here once we have completed that. But you can go in here and get all of the presentations that we did today and talked about for that. All right, just that was a quick reminder of making sure you utilize Basecamp to its fullest potential. And again, I will make a quick announcement through Basecamp today that will make that a little more available to you for this presentation. All right, thank you, Mikey. Appreciate that, sir.
Thank you.
Yep. So this will be a quick update on the CQM plan updates. The leadership, CQM leadership will be updating that plan and come to our July meeting to review the updates and the draft of that plan for this committee to approve and to move forward with. So that means that we have to update all of our performance measures, and we'll bring that will be the bulk of our meeting in person next month, is to really look at that plan, look at the, look at the infrastructure, look at the quality improvement, look at our performance measures, and determine, is this the direction that our committee wants to go with going forward? So we'll have some aggregate data presentations. You'll see how to get that data presentation today when we get to RDE and they talk about, the new components of eCompass. So we're very excited that this hopefully will help make CQM projects and quality improvement projects a little easier to identify and to do moving forward. Any questions about the CQM plan updates? All right, we will have that draft for everybody at the next meeting.
Thank you.
You're welcome. All right, RDE, updates from RDE. I will stop share and turn it over to them.
All right, yeah, let me just share my screen. All right. Okay, so we made some updates to the HIV care continuum dashboard. So it's a little more useful for your team to see who's in each denominator and who's falling out of it. So to access it, the same as you did before, on the main set of tabs, you can click on dashboard and it'll bring up the updated dashboard link for you. And for providers, you'll be locked into your providers, your particular agency, so you can see the clients that you've been servicing. You have a few set of filters, so you can filter by funding source, your contract, a date range, your service and subservice, and special population. So for this main set of filters above, it'll be basically just filtering the clients that will be pulled into this report. So if you set a 2-year period or just a 1-month date range, like in this case, this has just our current month. The report itself will be using a 12-month measurement period. So it'll go from the end date from whatever you set. So if you set it from last year, 2021, the reporting period will also go only up to 2021. So any HIV or any CD4 viral load counts or medications used for in this report will go up to that end date. So if you did provide someone afterward, it won't be included unless you modify the date. And it then leaves it further down the report. So let me just get a date range that has data. We'll go down below. Right. So the first table you'll see is our provider summary. So this will give you just a general overview of all the clients under each indicator. You can also see it just by the total row below. So under each particular indicator, we have two numbers here, one in blue and one in red. The one in blue are your clients that are in that indicator. If you click on either of them, it'll bring up a drill down for you. So you can see your EQID, first name, last name, and you can also just click on view and it'll bring you to that client's page. And again, you can do it also for clients that have fallen out of care, which is our red number. So for example, for linked to care, we have one that's linked to care, but two that have fallen out. I can click on that little two, and it'll bring up my two clients that are there, so I can easily see why they've fallen out of care or make corrections to that and rerun the report. And now for each of these indicators, you can find out what how a client can be included in that by clicking or just hovering over this little question mark, and I'll bring up a dialog box for each indicator. So for diagnosis of HIV, the denominator is the number of patients who received a service during the service unit's measurement period, which is again right above here if you just need a clarification on what that is. And the numerator is the number of patients in the denominator who are greater or equal to 13 years of age with an HIV infection at the end of the 12-month measurement period. And again, the 12-month measurement period is right here above again for clarification. And those will be the clients in there. There's also just one exclusion, which are patients that are less than 13 years of age. So that'll be carried on for all the indicators. So for linked to care, again, it's the same number of patients with greater than 13 years of age, diagnosed with HIV, who've had a service within that 12-month measurement period. Excludes patients that are less than 13 years of age. But for linked to care, it's the number of patients in the denominator who are linked to care with 1 month, within 1 month of their diagnosis, and evidenced by documented by a CD4 count or viral load test. So that's how we're tracking at your linked to care. For recipient care, the same denominator. The only additional exclusion is that they have to be alive during the 12-month measurement period. But the numerator is the number of patients in the denominator who had a care visit in a 12-month measurement period as measured by a CD4 or viral load test. For retained in care, again, the same denominator and exclusions, but now for numerator, number of patients in a denominator who had 2 care visits with at least 90 days apart during the 12-month measurement period, again, measured by a CD4 or viral load test. Prescribed ARV therapies, same numerator and denominator, or same denominator and exclusions. The numerator is number of patients in a denominator who had a care visit during a 12-month measurement period as measured by a CD4 or viral load test, and were also prescribed HIV antivirals during a 12-month measurement period. And then finally, viral load suppression is a number of patients in the denominator who had a most recent viral load test in a 12-month measurement period that showed an HIV viral load suppression of less than 200 copies per milliliter. So those are the indicators we'll be tracking. Again, you can just hover over the question mark if you have a question of how clients included in there or why they may not be showing up. And then for various breakdowns we provide, we have a gender breakdown, breakdown by race, ethnicity, age, transmission, your special population, which is Black MSN, Latinx, or transgender. And we have our core and support services. So these are basically our the way the RSR will break it down. So if you provide that particular service, it'll display here. If no one else provide any services, the table may be empty or have less or more options depending on your agency. But it also has that breakdown here as well. So the totals in these tables may have greater than your agency because the client can be in possibly more than one particular indicator for this section. And then lastly, above, you have the ability to enable charts. So if you click yes and run the report, you'll have charts display for all the particular breakdowns. So you have a visual representation of everything. For your agency, you can click on the little cloud icon here, and you can copy the URL or copy the image if you need it for a presentation or any of your documents. And as well, you can export this report to PDF or Excel. Again, just to make it easier for when you need reports, you need to submit a report, you can just click on those. And lastly, for whatever reason, if you need to view the legacy report, we still do have that available. Just click on View Legacy Report, and that'll bring up the older care continuum that we used to have. But any questions on how to use this report?
So Ms. Tisa, by chance, were you able to kind of click around in there to see if it give you better indicators or better updates on those CD4 count viral loads that you had entered?
Yeah, well, the thing, the thing about it, he did buddies, so it's only showing, the presentation at this time is only showing buddies information.
Oh, yes, ma'am, but I wasn't sure if you were able to sign into eCompass and run that same time period.
No, I didn't, I just.
Oh, okay, okay.
Yeah.
Yeah. Yeah, this was Buddies. This is a demo site anyway, so this is a scrambled data. If you do happen to see no numbers here, that may be because you have LKM locked. You need LKM unlocked to at least get numbers in here, since it's using age range for the exclusion. So if you do see nothing in this report, it's because most likely your LKM is locked. Again, for Tisa and Jerry, just also make sure on your CSX extract, it may be the 2-date range. So if you're running for a previous year, the viral load and CD4 counts will go up to that particular date. So in this case, it'll go up to the end of 2021. So if you do need probably a more future or the most recent ones, you may just want to increase that to today's date, or even like the end of this year. And that may be why you're not seeing those numbers, because they'll just go up to that date range.
Okay.
Wait.
Right.
Hello? Can you hear me?
Oh,
hello?
Yeah.
Okay, point of clarification, and I thought I said this. We did from 9/1/21 to 2/28/2022. The client was seen during that period of time. And the CD4 viral load was updated during that period of time. What are you saying is missing?
Yes, so if that's the case, just send me over that E2ID and we'll check that client. But this will check your services. So if a client was serviced within that period, it gets pulled into this report. But at the same time, it will also pull only up to that end date for your CD4 and viral loads for that particular one. So it goes up to that particular date. So if I ran this report for, again, last year, if you did update your CD4 even the day after in January of 2022, it won't pick it up because it was after the 2 date. So it might be that why you're not seeing your latest numbers.
Oh, got you. So it's not updated on the date the CD4 count or viral load were done. It's updated on the date that they were entered.
Right. So if,
so the result date,
We'll look again at it.
If the client's CD4 count and viral load was entered March the 5th, 2022, when the report was printed out, this was ran this morning, it should have been in there. It still had it only. It had November the 1st, 2021, but when she did the client's update in March of 2022, what was entered into the system should have registered and been brought over when the report was ran this morning.
But we'll
yeah,
check
it depends on that end date. If that was in February, then it wouldn't pull up.
Right,
But,
we had February in there, so we'll check it again.
Yeah.
And she updated it in March, so it would not have been in there.
Because
So
that's
we
what
have to change. We have to change the date.
Yeah.
Yeah, it's not pulling. Yeah, it's not pulling the latest value. Just for all the current date. It's just pulling up to the end date. But if that does need to be changed and that's more useful for your team, then we can look into updating that. But yeah, at least at this point, that's how it works up to this end date for your CD4 medical as well.
Well, we'll see how it goes.
We would, just to get accurate data, I think we would probably want to update that report to be reflective of the date the viral load and CD4 count were run, instead of the date that they may have been entered, because just for the fact that we're not going to get good continuum of care data if it's registering the date that it was entered and not the date that it was completed.
No, it's the result date. It's not the date entered. So it depends on what the result date before was that client.
Oh, okay, roger that. Okay. So
Yeah,
that
so
is
you can
the
enter it
result.
today, but it wasn't entered for March. Yeah, that's fine.
Okay,
Before
okay,
that date.
perfect. Okay.
Because even if we see a client, right, today, like say for instance, in March, we begin updating our files, right? But the last time that the client seen their primary care physician was December the 15th, 2021. The lab work is still good because it's only 3 months old. But the fact still remains that it's not the entering date that we entered it in, because it would be in March, but it's the date in which the client was last seen by their primary care physician. So when this individual that we're talking about, it was entered in the last visit for March the 5th, 2022, but it's showing its previous entry of 11/1/2021. That's what, our discrepancy here is.
Yeah. Yeah, just check that end date, because if it was February, it won't show up. But if you update again to like March, end of March, then that will get the latest date range.
Okay.
And then that's also something to keep in mind as well, the 12-month measurement period, because these indicators will be using that count to detect if it's like retained in care. So if you do have that extra range, if you need a 24-month measurement period, that's something you want to maybe bring up the CQI team meeting here to update that indicator, if that's going to be the case. But right now it's going to be using this measurement period. So if you do fall out of that range and you're not in that 90-day period, it will show up as a non-compliant client.
Okay, well, as long as you can pull it up right.
But it is in that the info here, so it does say that 12-month period. So if it does need to be updated, just bring it up, and we can discuss on these meetings if we need to update the indicator.
Okay.
Any other questions about the care continuum?
Well, I just ran the report and I don't know, like one is a female and, her ID is an F, but then in the sex section, she's listed as a male. So is there a way to edit this?
If you click on that client's record, it is the E2 ID that needs to be corrected, because they just may need to send it over to support for us to update it if it was changed afterward.
The ID is correct, but then, when the report prints out and there's a section for sex, she's listed as a male.
Is this a transgender person, Paula?
No.
Yeah, double check that record. If you click on that client and you go on to view, it should open up that record and you can see what's the latest gender that was set. Because if it did change afterward, that might be why it's showing incorrect. Otherwise, you can just email that E2 ID to support, and we'll take a look into that to see why that client is showing up in the incorrect spot.
All right, thanks.
All right. Thank you, Robert. All right. The last part of our meeting today is just going to kind of briefly go over.
Thomas, can I just say one other thing?
Oh, yes, ma'am.
There's a client on my report that I don't know. She is definitely not one of my clients.
Okay. And I'm going to assume that Robert's going to tell you to send that E2 ID over to the help desk. And
all right, I'm
we'll
gonna
see why it's showing up there.
I'll wait till I go through it all, but yeah, I don't know what's going on. Okay.
Thank you. All right. And then, so we will move on to subrecipient operations and updates. Since we're not amidst the main COVID stream, are there any subrecipients who have any updates with operations or announcements from their organizations at this time? All right, so this will be changed to the 13th now. So our next meeting will be July 13th. It will be in person. We highly recommend it to be in person if you are able to make it. If you are not able to make it, it still will be hybrid. So you'll be able to join virtually, and we will let you know location of the meeting as soon as we get that all figured out, along with the subrecipient meeting for Part A operations. If there are no other questions at this time, I would like to thank everybody for joining us today. The next meeting, again, we will start reviewing the updates and our new quality management plan and look at those indicators and performance measures. And then again, we will kick off our new PDSA cycle around August. Once we get all of August, September, as soon as we get our quality improvement and quality management plan completed. All right, no other questions. I hope everybody has a great day. Please let us know if you have anything that comes up. And don't forget to check Basecamp for updates. All right. Thank you, everyone, and have a great rest of your week.
You too.
Thank you.